Bismillahirrahmanirrahim. The next topic of our discussion is esophageal adenocarcinoma. So, esophageal adenocarcinoma is actually the neoplastic proliferation of the intestinal metaplastic cells which are formed due to Barrett's esophagus. As we already discussed in Barrett's esophagus, the normal squamous epithelium of the esophagus undergoes metaplasia and converts into the columnar cells. These columnar cells are considered to be pre-malignant and often they indicate dysplasia. The dysplastic cells within the intestinal metaplastic cells are considered to be pre-invasive. Therefore, the adenocarcinoma of the esophagus arises in the background of gastroesophageal reflux disease and Barrett's esophagus. The risk factors for esophageal adenocarcinoma includes gastroesophageal reflux disease, tobacco smoking, obesity, and prolonged and multiple radiation exposures, such as mediastinal X-rays or thorax X-rays. There are certain factors which are associated with the decreased risk of adenocarcinoma. These factors include a diet rich in vegetables and fruits, and moreover, there is a decreased risk of esophageal adenocarcinoma in H. pylori gastritis. This decreased risk of adenocarcinoma is probably due to gastric atrophy, which is resulting in decreased acid reflux. Coming on towards the pathogenesis, so Barrett's esophagus is actually a long-term complication of gastroesophageal reflux disease, and therefore the mutations accumulate over a long period of time in the metaplastic epithelial cells. These mutations are typically in the tumor suppressor genes and proto-oncogenes. The tumor suppressor genes mutated include P53 and P16-INK4A. These genes are typically the tumor suppressor genes which control the cell growth. Once these genes are mutated, there is a loss of check against the cell growth, hence resulting in an increased growth of the tumor cells. The mutations in the tumor suppressor genes are typically the loss of function mutations, since these genes have lost their function to check the growth. Moreover, the proto-oncogenes include ERBB2 gene, cyclin D1 gene, and cyclin E gene. These genes normally increase the growth and proliferation of the cells. So proto-oncogenes undergo gain of function mutations. So in gain of function mutations, the function of these genes, which is to increase the growth and proliferation, the function gets enhanced. So there is excessive proliferation and excessive growth of the tumor cells. So the mutations in the tumor suppressor genes as well as in the proto-oncogenes result in increased cell growth, forming adenocarcinoma of the esophagus. Esophageal adenocarcinoma is typically present in the lower one-third of the esophagus, since this is the only site of Barrett's esophagus. Grossly, the tumor appears to form a raised or a flat patch, or in contrast, it might undergo an infiltrative growth pattern. The first point on the histology is the pattern. The pattern means what kind of structure the tumor cells are forming. So as this is an adenocarcinoma, adeno means glands and carcinoma means malignant proliferation of the epithelial cells. So the pattern in esophageal adenocarcinoma is glandular, and these glands produce mucin. As you can see here, there are multiple glands present in the tumor. The second point on histology is the cell characters. The cells in the adenocarcinoma are columnar cells which might be well differentiated, resembling the metaplastic columnar cells, or they may be poorly differentiated. The poorly differentiated are small cells with central nuclei and round shape. These small cells typically resemble the small cell carcinoma of lungs. In rare cases, in the infiltrative type of adenocarcinoma of esophagus, signet ring cells might also be present. These signet ring cells are exactly the same signet ring cells which were present in the gastric adenocarcinoma. These are round cells with a large vacuole pushing the nucleus to the periphery, hence forming a typical signet ring shape. The third point in the histology is the presence of a specific feature of the tumor. In this case, the features of Barrett esophagus are present adjacent to the tumor patch. So features of Barrett esophagus includes intestinal metaplasia of the esophageal mucosa. Intestinal metaplasia is typically characterized by the presence of columnar cells and pale-colored goblet cells. The fourth point is that there are excessive mitotic bodies in a malignant tumor. And the fifth point is focal necrosis, which is hallmark of malignancy. So the esophageal adenocarcinoma is often discovered incidentally on the histological evaluation of Barrett's esophagus. In contrast, the symptoms of esophageal adenocarcinoma include dysphagia or difficulty in swallowing. There might also be centralized chest pain and weight loss. The tumor is diagnosed on the endoscopy and histological assessment of the biopsy, and radiological imaging is done to determine the local extension of the tumor and metastasis. The prognosis of esophageal adenocarcinoma is good in the early stages when the tumor is limited to mucosa and submucosa. In these cases, the prognosis is good and 5-year survival rate is greater than 80%. Whereas in the late stages, when the tumor spreads to lymphatics, the prognosis of the disease is poor, with 5-year survival rate less than 25%. So this brings us to the end of discussion about esophageal adenocarcinoma. If you have any questions, do let us know in the comment section. Thank you.